Hello everybody and welcome to session 2, this panel discussion on futuristic genetic counselling, working as part of an MDT, mainstreaming and evolving diagnostics. My name is Anna Middleton and I'm a genetic counsellor from the United Kingdom, and I'm on the steering committee that's helped to put together the programme for the World Congress. And in this session we have Catherine Beard from Australia, Stephanie Cohen from the USA, Alessia Costa from the UK, and Emily Higgs from the USA. Now this session we really wanted to debate and discuss the evolving role of the genetic counsellor. And in the introduction I mentioned the word mainstreaming. So we know that clinical genetic services with genetic counselling in it has been around for a very long time. Genetic counselling as a profession has been in existence for many, many years. But as genomic medicine has evolved and developed, so too has the practice of genetic counselling. And genetic counsellors, many of us, have left clinical genetic services and now work in other disciplines or in other areas. So the practice of mainstreaming, and this is a term that's often used in the UK and Australia, means working within mainstream medicine. So genetic counsellors may sit within breast cancer services or bowel cancer services, or be the genetics expert in the dermatology clinic. They may mentor and support nurses to run their own family history clinics. They may work directly with oncologists to help them do their own genetic counselling. So this panel discussion is all about that evolving role and thinking where are we going as a profession? What are we currently doing at the moment that's left current clinical genetic services? Are we still line managed by those services, or do we sit within other disciplines across medicine? And we also want to look to the future. So thinking about diagnostics at the moment is fairly clear within the genomic medicine remit, but how does that evolve to not only just include genomics, but multi-omics? And also what about the use of wearable technology in the future? So for example, to track cognitive decline. And the data that is gathered about us, that's health data, could that at some point turn into diagnostic data that could then be used by genetic counsellors in a clinical setting? So that's the themes that we're hoping to discuss, and our panel members are fully set up to brief us on the areas that they're working on and then looking to the future where they see practice going. So I'd like to introduce each member of the panel to introduce themselves, and then from then on we'll look to the future. So starting with Alessia, could you tell us about your work at the moment?
Hi, thank you for the introduction, Anna. My name is Alessia Costa. I'm a social scientist by background. I have done research in the genomic clinic, but I don't have a clinical background or expertise myself, as I'm a social anthropologist. And I am a postdoctoral fellow at the Wellcome Institute, working with Anna and other colleagues doing social research particularly on data-driven medicine, so data-intensive approaches within and beyond genomics. And my last research project was about digital phenotyping, particularly using data from wearable technologies to detect early signs of disease, such as in the case of cognitive decline associated with dementia. And so I think there's a lot of synergies and connections with genetic counselling and future models, as that's what I'm looking forward to talk about today.
Thank you, Alessia. And over to Emily.
Hi, I'm Emily Higgs. Great to be part of this discussion today. So I am originally from Melbourne, Australia, where I did my genetic counselling training and worked as a clinical genetic counsellor. And now for the past several years, I've been in a genomics research lab at Stanford University in California. And it's a genetics lab, but has ventured right into the space of multi-omics and precision health and wearables technology as well. So I do a bunch of interesting things there. And so a couple of those things are that I'm involved with a study which we call IPOP, Integrated Personal Omics Profiling. And as part of that, I consent participants do their variant analysis and return findings to them. They're ostensibly healthy participants, and they have the option to opt in for receiving both actionable and non-actionable genomic findings, and can receive all their raw data from the study as well. And then during COVID, in the past 18 months or so, a lot of our research studies were put on hold, as other people might have experienced too. And so the lab that I work in, and then also myself, shifted towards working on studies using wearables technology to try to develop early detection systems for COVID-19. And so my role in those projects was really helping to make decisions about how to handle the data, because there ended up being quite some similarities between genomic data and wearables data, and kind of how to manage that and manage potentially medically relevant findings, and thinking about privacy implications and things like that. So that's what I was doing more recently.
Fantastic, thank you, Emily. And over to Catherine.
Hi, I'm Catherine Beard, and thank you as well for including me in the session. I'm a genetic counsellor based at the Parkville Familial Cancer Centre in Genomic Medicine, which is a traditional, I guess, genetics clinic based inside two different hospitals, the Royal Melbourne Hospital and Peter MacCallum Cancer Centre. And I work, I guess, in quite a large team and a subset team of genetic counsellors who oversee a cancer mainstream program within those two large hospitals, but also at our regional services around the state of Victoria. The streams that run as part of that program are in ovarian, breast and pancreatic cancer, and I guess potentially expanding in future. And I guess those programs run with oncologists, surgeons, nurses in the oncology setting, ordering testing for eligible patients and giving back results. And we oversee that testing and then see patients where there's, pathogenic variants identified, complex cases, family history, and those sorts of things. And I guess liaise between the laboratory and those clinicians as well to help support that testing.
Fantastic, thank you, Catherine. And over to Stephanie.
Hi, my name is Stephanie Cohen. I'm a genetic counselor in a cancer genetics program in Indianapolis, Indiana, here in the United States. So my interest here really is how to improve access for genetic counseling services in a larger geographic area. In our state of Indiana, we found that there were very few cancer genetic counselors outside the big city. And that was an issue for our patients to access services, because this has probably been a work in progress for the past 10 years. Not many providers were doing genetic testing outside of genetic counseling. Our first approach was, we have some smaller hospitals within our health system. And so we reached out to them and started providing outreach clinics, which I think many of us have done, where we physically drive to the outreach site. That became limiting because we were there once a month, and that wasn't really enough time for the patients, and they started to pile up. So we started collaborating with nurse navigators on the ground, which we call genetic extenders, or genetic counselor extenders. And those individuals we trained very closely, one-on-one, and then we developed a webinar series because the one-on-one training was a bit much with the turnover. And so we do a triage process whereby very individuals who meet criteria very clearly or have pretty straightforward indications, similar to the mainstreaming that you're hearing about with pancreatic and ovarian and some of the clear-cut indications for hereditary cancer. And those individuals meet with the extender and go through the risk assessment and informed consent. We're available now by telemedicine if there are if there's a positive result, or if it's a really complex family history, we would meet with that patient up front. So we've been able to reach a much broader number of individuals within our health system. In our pilot study, we increased our reach by about 4 times the number of patients by adding our extenders and using them. And then I'll just mention that another interest that I have personally, I've been involved with the National Society of Genetic Counselors and their service delivery model task force and service delivery model investigations. So I do have a strong interest in learning about other service delivery models that are out there and what can we do to improve access. And then my other plug will be for quality and looking at outcomes of these as we make changes to try to improve access.
Can I just ask you a quick question about the nurse navigators? Where does the liability sit in terms of the care, and you know, are they responsible to the genetic service providers or to their own line management structure? Presumably that's within nursing, within a separate setting from where the genetic counsellors are. How does it work in terms of liability?
Well, we're all under the same umbrella in terms of our health system because we do work for the same health system. So I don't think that's been an issue in terms of who they report to. You know, we are within separate hospitals, but again, under the same health system. So they don't report up to us specifically, but we are very hands-on in terms of the patient care. So we review all of the family histories and all of the genetic test results before they would contact the patient with that result. So ultimately, we also do chart reviews where we make sure that their notes are complete. We've given them templates for those notes. So, you know, but I think because we're within the same health system, it hasn't been an issue in terms of liability.
So you're quite closely connected to what they're doing, and they're using the same protocols and triage system that you've defined. And are there enough genetic counsellors of you to go around for the volume of work? Is that sustainable?
So far, it has been for us. We've been trying to track some metrics so that we can, you know, scale up and do this in a larger health system. So our health system within the state of Indiana has 14 hospitals, but we are also part of a larger health system across 30 states. And so our goal is to replicate this in other systems where they don't have many genetic counselors or any. And so we do support, we have 3 sites where we have extenders. There are 3 full-time genetic counselors. One of the sites has 5 extenders and just was able to hire a genetic counselor of their own because they were, we demonstrated the need for that. But on average, we spend about 6 to 7 hours a month, each of us, to support these 3 sites. So it is very sustainable on top of our additional seeing patients that are either triaged to us or that are within our own hospital.
Yeah, fantastic. And Catherine, could you chip in here? Is with the model that you have in Australia, and how different is it to what Stephanie's been describing?
So it sounds, I guess there's definitely similarities. In our ovarian cancer stream, there is a nurse that I guess does see most of, if not all of, ovarian patients when they're diagnosed. So she is a good point of contact where she can identify those people as eligible for genetic testing and flag it, and often does the consent herself in, I guess, in conjunction with the doctor or the consultant seeing those patients. In the other settings, it's mostly the doctors seeing the patients who are assessing who's eligible and consenting and ordering the test. Our eligibility criteria are quite distinct, so we've tried to make it really clear, black and white, either, you know, the patient is eligible or they're not, and if you're concerned that they should should still benefit from genetic testing, you can still refer them to us in the traditional model for us to assess. And I guess, like Stephanie was saying, we work quite closely with those teams and sort of have points of contact. We try to do regular training, which is usually done through an in-service. So we go to the hospital and invite all the clinicians and nurses to come along. We try to do it every year. Obviously, with things like COVID, that doesn't always go to plan, but I guess as new doctors are rotating into hospitals and out, we try to keep that up to date. Yeah.
I think that's a great point. If you don't mind if I jump in real quick, we have definitely put a emphasis on the continuing education for our extenders, and we have a case conference where we meet once a month, present a journal article for the first 20 minutes, half hour, and then we present cases that are shared between the different sites. And that gives us an opportunity to make sure that our extenders are kind of up to date. And then on top of that, we have a monthly meeting where we talk more logistical, changes in laboratory processes and test collecting and things like that.
Given that genetic counsellors undergo such detailed training to become genetic counsellors, and also the certification and the registration process is also very, very tight and arduous, and we have to be very highly skilled to pass all of that. What aspects would you say of genetic counselling are the most easily transferable to other professions? So they're not obviously being genetic counsellors, but what is it that they are doing of what genetic counsellors do? Can you sort of distill what those skills are? And has it been okay to let those go and hand those over to others to do well? Catherine, how's that worked in Australia?
Great question. And it's interesting, I guess, even coming to do this talk, I've had to really go back and think, when we started, how I was feeling compared to now. And definitely when I started, there was just a small level of anxiety about, well, how is this going to go? And lately we have been doing some research into patient experiences of the program, which thankfully has been really reassuring. But to answer your question, I guess obviously consenting people to tests, or procedures where there are risks and benefits and all those sorts of things. Definitely people who aren't healthcare professionals who don't have a genetics background have that training, and that can't be underestimated. Obviously, through upskilling them in genetics, we can flag the specific things that come under the genetics umbrella in that regard. And we provide an information sheet that they can give to patients at the time of testing as well, to provide those details on, in the written word. And I think obviously in this setting, the test is often, part of diagnostics and making, say, a treatment plan, not always, but a lot of the time. And so, I guess their focus is on that element of the test, and I guess the outside elements come back to us, so the familial implications, the other cancer risks, and all those sorts of things.
And do you feel confident with the skills that your colleagues, your non-genetic counsellor colleagues have, that they have enough of the genetic counselling that you've imparted to them to do a good job? And that's evaluating well, I presume, but I just want to get a sense of how you feel about letting go part of the genetic counselling practice.
I think they do. I definitely don't think it's as good as a genetic counsellor, and I guess there's that tension because, of course, as you say, with our training, we are best placed to do genetic counselling. I believe that as a genetic counsellor, but the tension is that the demand is so high. The resource of genetic counselling is low, and these patients still really need have access to genetic testing. I think the thing, as I was saying, that feeling has sort of shifted over time. And at the moment for me, in our most recent study that's still ongoing, we're really hearing from patients who've been through the process that have valued so much having the test done with their non-genetics health professional, so with their oncologist, their surgeon, because that person is someone who's seen them through their cancer journey. It's someone they trust, they have a lot of respect for, they're time poor, they have a lot going on, and the thought of having to meet another person, add more appointments is just a bit too much. And I think in the past, I was so held on to, we are the best at this, they should come see us. But that, you know, it was client-centered, but at the same time, that, you know, these people are telling us that they're okay doing it this other way. Of course, they don't know what they don't know. They don't know what they've missed out on, but I'm finding that reassuring, I guess.
Mm. So if we were to think about these models being here to stay, so that it's evolving practice, and other professionals are taking on some of the skills and the magic of what genetic counselling is, the genetic counsellors are having to leave some of that in the capable hands of colleagues and trust that that works. If we sort of step forward 5-10 years, how can you see practice models evolving? So can I start with Emily, and we'll go around the panel. So if we think forward into the future.
Yeah, I think Catherine and Stephanie can speak best to how they would see kind of mainstreaming or integrated models of genetic counselling evolving, but I can speak a little bit to my experience that I've had with multi-omics and with wearables, and also with offering a lot of information back to participants or patients, and kind of being interested in how they react to that. So in terms of multi-omics, I think that's a space that's growing very quickly. And just to define that, I guess, a little more for people who aren't as familiar with that term, you know, we talk about genomics, but you can also add to that looking at the transcriptome or the epigenome. And then you can even take it further and look at the metabolome, the microbiome, the lipidome. There's pretty much an ohm for anything if you're looking for it. So I think what I'm seeing and hearing in that space is that you know, that can be really used in two directions. So one is looking at a genotype, a known genotype, and then trying to understand more about the phenotype by kind of deeply profiling a lot of biological signatures or patterns in that individual. Often multi-omics is done longitudinally too, so kind of looking at how things change over time. And then I think it can go the other way too. So taking, for example, someone with an undiagnosed disease and looking at a multi-omics profile to gain insights into potential causative genes or biological pathways that could be involved to help with diagnosis or even potential treatments. So I think both of those things are happening and evolving, and I imagine we'll see more of that, and that becomes relevant for our patients in genetics who might be, you know, this might be a part of a standard workup of someone with a rare condition or undiagnosed disease. And we're seeing that in a little bit in research. There's a large research study across the US, the Undiagnosed Disease Network, which is now including metabolomics and lipidomics into their workup and thinking about how to kind of share some of that information back with participants as well. And I think genetic counsellors potentially could have an interesting role there, as already being very well versed in discussing technologies with patients and uncertainty and you know, findings that don't quite make a diagnosis but may be helpful and may be more helpful in the future, and all those kind of concepts I think carry across. So that's kind of my thoughts about where that's heading.
And is your sense that in a way the sort of the multi-omics is the full kind of body profile, isn't it? And do you feel that there could be a branch of genetic counselling that could be the professional group that holds all of that together for the whole of the patient, the holistic experience of the patient? Or would that be a different sort of health professional? What's your sense?
That's an interesting question. And yeah, it gets at that point that, you know, when there's just so many branches coming together, you know, it really serves a patient well to have kind of a coordinator of all of that. Well, so I had an interesting experience a couple of years ago. I went to a proteomics conference, and of course, a lot of the science went over my head, but I was really interested in some of the discussions where the proteomics scientists were really saying, you know, those geneticists, they think they're the kind of the main ohm or the primary ohm, but you know, really proteomics is the main ohm. It should be the central part of healthcare and medicine. And so I found that fascinating to just think about, you know, what are the other perspectives that we're not looking at from our position. But I also think, you know, we're a unique profession where we're trained in counselling and communication skills and case management and patient advocacy. And I can't think of any other branches of omics that have that kind of professional embedded. So I think genetic counsellors will be well positioned for that if it's a space that we wanted to go into.
Gosh, that's interesting, isn't it? So many transferable skills within genetic counselling that we could be quite appealing to other professions to, because it's got a ready-made package for managing the patient, haven't you? Can I bring in Alessia at this point? Because it'd be lovely to hear some of your work about using wearables and the sort of the use of data to potentially shift to diagnostic data, and who might help counsel individuals with that data.
Yeah, kind of building on what Emily was just talking about. I think that it's interesting to see how other specialties, other domains of medicine are increasingly facing some questions that genomics have long been grappling with, and how, sort of like the skills of genetic counselors might become more transferable to other domains. And I'm thinking in particular 3 sets of challenges. And on the one hand, we have, I think, the increasing role of patient-reported or patient-generated data in constructing clinical profiles. So I think in this case, even data from wearables, approaches from digital phenotyping might become more sort of integrated in genomics research, but possibly in the future genomic care as well. The other thing that conceptually I think is quite interesting is how changing models of identifying and managing disease and conceptualizing disease are sort of increasingly becoming common in other domains of medicine, which have long been established in genomics. Particularly, I think the idea of moving from the concept of just diagnosis on the basis of symptoms and clinical testing to concepts such as well, in genomics, we have this idea of sequencing, but it's interesting to see how, for example, in digital health, you have idea of constant, continuous monitoring, even self-monitoring, or the idea of early detection on the basis of, so pre-symptomatic detection of possible indicators of disease on the basis of, well, in the case of the wearables, it's digital signals. Obviously, in the case of genomics, would be genomic variants. And that kind of shifts, if you want, concepts of disease from what is called an ontological model of disease. So either you have it or haven't got it, to a more sort of what is called quantitative ideas of disease. So kind of how much disease you have, how can you stratify disease? And I think increasingly we will see that more and more, possibly also in other domains of medicine. And I think, again, that's sort of questions that genomics have maybe been grappling with for longer than maybe other disciplines. And I think all of these kind of raise questions where the skills of genetic counselor might be particularly valuable, especially if we collect more and more data, not just in the clinic, but also from different domains of wearables, data collected at home, data reported from patients, data generated in the sort of like the space of direct to consumer technologies. So I think some of the questions, some of the areas, if you want, where some of the participants in our studies on wearables were drawing parallelism with the profession of genetic counselors are the issue of consent, which Emily was alluding to. So how do you do consent in the case, for example, of, well, first of all, when consent is done remotely, when you're not able to provide full information about what we might find out. So there are limitations to how much you can prepare patients or users to the findings, but also like interesting consenting to the limitations on informed consent and confidentiality that you have in genomics. How does that transfer to the case of wearables, which, as Emily was just saying, sort of generates data that can never be fully anonymized. So you have obviously issues of privacy and possible discrimination there. Another thing that I think is very interesting, which kind of links back to this idea of, well, changing models of disease and blurring the lines between what is clinically significant, what is not, what is disease and what is not, is the idea of interpreting data. So in our studies, we saw a lot of that when sort of like with the case of continuous monitoring, it's like at what point does a trajectory of decline, for example, becomes clinically significant? So for example, with the apps that we have been studied, a lot of those are marketed or potentially designed to potentially marketed to users with the idea that you could track and at the same time train your brain health to keep your brain healthy. But as one of our participants put it, well, when you do Sudoku with a pen and paper, you just do Sudoku. But when you're able to visualize your results in the long term, you might be able to pick up changes, you might be able to pick up decline. So at what point those data become clinically significant? Would they start to give you an indication on your health? And so I think it's about sort of, that raises a lot of interesting question about, well, how do you define threshold? How do you define the potential clinical use of those data, but also what do you report back to patients and users? How do you report it back? So do you give a score? Do you just give a possibility to visualize performance data? And even if you just visualize performance data without giving any clinical indication of what that might mean, well, how do you help patients cope with that, or users? And how do you help them to effectively use those tools and those information? So I think these are all areas that came out in our study, which apparently is miles apart from the genetic clinic. We're talking about wearable to detect cognitive declines and do sort of Sudoku on an app. But it's interesting to see how many of the questions are similar. So I think there's a paper that we have put in the for discussion. We talk about from sociologist working on data-driven medicines, and they talk about health information counselors. And I think, yeah, they see that as a profession for the future for precision medicine and data-driven medicine beyond genomics. And I think obviously genetic counselors might be the kind of model that already exists on which this health information counselor might be drawing on. So I see, yeah, a lot of transferable skills there.
Wow, health information counsellors. And in earlier sessions in the Congress, one of the keynote speech was about the evolving profession of genetic counselling and how long it has taken to get to this point. And if we were to evolve a whole new profession, that's quite a big task and a big ask. So really interesting to see if that might take off. But yes, certainly driven from the direct-to-consumer testing market, there definitely seems to be a demand for support and help with customers. And whilst the direct-to-consumer testing market was always designed on the premise that it's direct to consumer and there is no middle person who's there to help pick up the pieces or help guide choices, it's becoming more and more obvious that there is a need and a gap to be filled there, isn't there? And that people do want and ask for help to make sense of the information they're given. So continuing with the theme of where will we be in the next 5-10 years, Catherine, would you be able to just sort of say a few lines on where you think mainstreaming will be going?
Yeah, I think it's going to continue to move, you know, I guess the way it has been, but expand to more and more different streams. I guess obviously I work in cancer, so that's my focus, but I'm aware of this happening in other disciplines in neurology, endocrinology, you know, we have cardiac clinics and those sorts of things as well. And I think there, as I mentioned before, if the test, I think the consenting process can be done in this setting, can be done by someone who isn't a genetic counsellor if they've had some type of upskilling or training. But as you get to a more complex test, like Alessia and Emily have been talking about, or even thinking about, you know, exomes and genomes and things, then that's definitely a bit more grey, just because of the potential findings that might come out, particularly if someone's choosing to have non-actionable, you know, secondary findings and things like that. But I think it's going to continue to expand. I think, you know, particularly, I'm curious, I guess I don't have sort of a solid answer, but I'm definitely curious about things like, you know, polygenic risk scores and that sort of thing, which is starting to come into our area now, as in we're still sort of doing it in a research setting, but where a test result is so personalized and has less of those immediate familial implications. Of course, there are still familial implications, but it is really targeted at this person in front of you. Yeah, I'm curious how much of that will stay in our field and how much might move out into oncology.
Yeah, and I suppose the question for genetic counsellors is, do they want to retain hold of the really rare Mendelian single gene conditions, and they see that as what defines genetic counselling, and as genomic medicine evolves, it may be that other professional groups take on the polygenic risk scores and other omics perhaps, or do genetic counsellors want to evolve with that and then branch out? And I think it's not completely clear at this point, certainly in the UK, what the role will be. But I mean, genetic counsellors are so able to adapt to change. They're a profession that has evolved so quickly. And I think also the phenotype of genetic counsellors is that they're very often very willing to adapt and evolve their care. So we're at an interesting point in time, aren't we, as to how this will evolve 5, 10, 20 years time. Stephanie, do you want to reflect on your thoughts on models of care moving forward?
Sure, happy to throw some more things in there to think about. I think one of the things that I keep thinking about, where genetic counselors differentiate themselves in terms of our skill set. And I think one thing I think about a lot is unlinking that genetic testing from the genetic counseling. So, way back in the day when genetic counseling began, we didn't have a lot of testing options. We didn't know where many of these genes were. And so we were more focused on adaptation and what to expect, and kind of helping families understand complex information, but not necessarily testing and risk and again, adapting to that. So I think we've evolved from sort of that and more of a generalistic look as well. So a genetic counselor frequently would see patients in many different specialties. It wasn't that you were specialized in one area. And I think that, where we are now, genetic counseling tends to be linked to the testing part because we have so much testing available. But I think what we're learning is that not every person who undergoes genetic testing needs genetic counseling. And that's the trick, is how do we differentiate who really would benefit most from that psychosocial support? Who needs that additional assistance in that shared decision making? And then where we're going in the future may be very different than where we are today. Are we going, as we go to these omics, as Emily so nicely put it, we have multi-omics for everything, right? When we start doing these larger types of tests, you're going to uncover a number of different things in different areas. So someone might have a whole exome or a whole genome and find that they carry a mutation in a cardiovascular risk gene, hereditary cancer gene, and they may be carrier for something that they could pass on to their children in a think about preconception counseling. Right now, I'm not sure one genetic counselor would feel comfortable covering all of that information. So, are we going to be offering shared medical decision appointments where we have multiple genetic counselors contributing in a group type of setting? Or are we going to, and this is probably where we're going, is we're going to be educating our non-genetics trained physicians. Everyone will have some sort of basic genetic knowledge, genomic knowledge. We are not a genomically literate workforce yet across our countries, and we need to get there because genomics is going to be part of all medicine. And I think genetic counselors are going to be in the unique position of taking on those super challenging cases. But from the genetic counseling standpoint, we may be providing some kind of support to those other healthcare providers, whether it's e-consults or educational role, supportive role. But I don't think we'll be seeing the majority of patients that are undergoing genetic testing. I think that in 5 to 10 years, we're going to be in a very different role where we're in a more supportive role, educating and I don't know, holding on to those very challenging. I don't know if it'll be Mendelian. I think Mendelian cases sometimes are less challenging than the single nucleotide polymorphism, complex genetic information where you're combining all of that together. But yeah, so just some more food for thought.
Fantastic. So we've started to get some questions coming in, which is lovely, and they've been coming in for a little while now. So I think it'd be great to turn to a few of those. So a question from Amanda Piccini: have your nurse and non-genetic colleagues voiced what they think are the skills that genetic counselors provide that they feel they could, would or should not be doing themselves? Can I put that to Catherine first?
Yeah, so I think there's definitely a spectrum of different feelings amongst our non-genetics colleagues. There's definitely not a large group, but there is a group who haven't engaged in the mainstreaming program, so feel, it's just a bit beyond their remit, and some of that's about time. Do they have the time to do it? And for some, it's about comfortability, thinking about talking to their patients about genetics. But I would say the vast majority definitely feel comfortable consenting and ordering the test for their patients, the vast majority disclose test results, and that's regardless. So as in for positive results, negative results. I think variants of uncertain significance is an area where they get a bit, bit concerned that they might not be able to explain it quite right. And we have built into the program now that when a variant of uncertain significance is reported by the lab, that we'll sort of do an additional sort of analysis, I guess, looking at the patient's personal history, family history, and have sort of a geneticist review it and then feed that back to the doctor what the real take-home message is going to be. And if it's suspicious, we'll still see the patient to talk it through a bit more. The family communication and that sort of thing, and definitely predictive
Oh, Catherine's just frozen. We'll come back.
Oh, sorry.
Oh, no, you're back.
Sorry.
Go for it.
I was just saying that the familial aspect of it. So informing their, talking about the relatives and their risk, and then offering predictive testing for relatives is definitely still something that we do as genetic counsellors. And I think, they don't want to do it and don't have time for it. And I think they definitely see that as our role.
But also, I suppose the existing model of care across most of medicine is relationship between clinician, whoever they are, and patient. It's that one-to-one care. It's not patient and all of their relatives. And unless you're in, I guess, a general practice perhaps, or genetics. So resistance being, I don't really want to see this person's sister or child or whatever, because that's not what we do. That's what genetic counsellors would do. Is that the sentiment that you're hearing?
Yeah, I think some of these patients often have their family with them at their cancer appointment, so it probably it is coming up naturally with that doctor who's giving them that test result. And it's a very quick, I've had sort of, normally what they would do is we would liaise behind the scenes, and then we would contact the patient after they've been given their test result. But definitely there have been times where the oncologist or surgeon has called me during the appointment and put me on speakerphone because person X's sister is in the room with them and they've got some sort of immediate questions. Yeah.
And so that same question to everybody else. Stephanie, any thoughts about what other colleagues think they shouldn't be doing?
Yeah, I mean, our extenders are pretty vocal about that. And I think that it depends on the level of comfort, depending on their experience. So we have noticed that the number of questions we get from our extenders has decreased over the years. The more comfortable they get, the more often they do this. Our nurse navigators, extenders are very comfortable talking to patients, educating them, and obtaining informed consent. I think that the areas that they struggle with a little bit more, or they seem to have challenges, is more of the counseling skills, helping patients to adapt to this information, communicating with the other family members. So as we all do when we have a result that needs to be shared with family members, we provide some suggestions on how to reach out to other family members, some suggestions that way. And I think that's an area where they don't necessarily feel comfortable. They haven't been trained in that area. So I think from my perspective, it's more been the psychosocial and the counseling and the family communication skills.
But presumably in time, with more experience and more doing of it, and with the support that you offer, they could well be doing that in time.
Yeah, potentially. I think that there's a lot of other training that goes into it. So it depends on how much time they have to contribute to that. And, most of our nurse navigators are fairly busy. So I don't know that they, in time they probably would, but, that's not an area we've focused on. We've tried to make sure that we're triaging the pretty straightforward cases to our extenders, and then picking up where they don't feel that they have those psychosocial skills, or the really complex genetic skills. They haven't had the training and the background in the science. So explaining these very challenging results is something that I think is the other piece that they're missing.
And of course, with time and with more training and with more support, then edging towards the role of a genetic counsellor, aren't they? So it's kind of interesting to know where the boundaries are as to what is genetic counselling to be done by a genetic counsellor and what is an extension of a nurse navigator's skills that's within the genetic counselling realm, but it's not crossing over into, replacing a genetic counsellor. It's really tricky, isn't it, to know exactly where that boundary is.
It is, and I think that even in the past 10 years, our definition and processes have evolved to allow for that. So I think I always tell my extenders that this is an ongoing process. We're fine-tuning it as we go. We're kind of, and you're right, I think that we'll see where we end up. And I think we probably need to end up where there is a much stronger presence from non-genetics providers who can do a basic level of testing and providing information. I'm not going to call it genetic counseling because I think that I want to reserve that genetic counseling term for what it is that we do that is different from other providers. But I do think that many other providers should and could and will be ordering genetic testing and doing some level of education and have the proficiency to be able to use that information in the right way.
Yeah, I think that's really interesting. As a profession, taking ownership of the words genetic counselling as a verb, doing genetic counselling. And I know certainly working with clinical geneticist colleagues in the UK, there certainly are, clinicians who feel that they are doing genetic counselling. And, it's quite interesting when you challenge that, well, you're not doing genetic counselling as defined by what genetic counsellors do because you're not qualified to do it, but some aspects of what genetic counselling is, yes, of course you are doing, but it's sensitive, isn't it? And do we take ownership of the verb?
Right. I think that's a natural tendency we all have, right, for survivorship. That we have a unique role and position, and I think that having done this for a long time, we've had to define our role and demonstrate our value and over and over again. So I think that probably comes in very strong. We want to hold on to that. But I do think there are certain parts of it that we can give up and should give up and should make sure that we're working collaboratively. I think that's really the key.
Yeah. So I was involved in, so when I was the chair of the AGNC, which is the professional body for the UK genetic counsellors, and we were tasked with, for workforce planning, to really spell out in detail actually what a genetic counsellor does and what they do that's different from what clinical geneticists do. And given that there's so much overlap in the professional roles, and it was a very, very sensitive and difficult discussion with the clinical geneticists in the UK about ownership, because really there's a lot of commonality. So who owns what? And it actually came down to phenotyping is what the clinical geneticist felt that they wanted to own as very specialist to them. And basically everything else could be the genetic counsellor taking care of the family, variant interpretation even, the triaging, the risk profiling, the screening, the ethical issues, all of that became the domain of the genetic counsellor. So then when you start to look at long-term workforce planning, if the phenotyping is done automatically and the variant interpretation is done through a systemised process by the clinical scientist, the role of the clinical geneticist is then not really needed so much. So then there was a real sort of lots of angst around specialist phenotyping that only a clinical geneticist could do. and the pulling together of multiple phenotypes. So it's been quite painful and emotional, actually, discussing about role definitions and really trying to hang on to what is it that we actually do that you can map directly onto a patient pathway. Emily, you wanted to say something?
Yeah, I just had some thoughts as you're talking about that, you know, thinking about the definitions of the roles and training others to do similar tasks, and then what verb do you use for that? I think, you know, one thing that we as genetic counselors have is kind of a shared code of ethics and shared set of values and culture. And I think that, you know, doesn't necessarily get captured when you're training another health professional to do genetic counselling tasks. They're bound by a different code of ethics, or they might have different priorities in terms of their professional values. And so I think that's something else that sets us apart too. Like the example we were talking about in terms of thinking about the care for the family, probably most healthcare professionals are very trained in the model that their patient is their client, or you know, the person they are serving. But as genetic counselors who have had a different model of training and different kind of professional culture, we might see the family members kind of as an extension of who our patient is. And so I think there's differences there that just don't get captured with training necessarily.
Yeah. Okay, so just a few other questions. So from Michelle Moore, do you have any patient contact, or how do the patients get notified of their medically actionable or non-actionable results? I think this must be for you, Emily.
Yeah, yes, I see the research participants. The study is longitudinal, so sometimes you know, someone before me who consented them some years ago, and I'm seeing them to return the findings, or I'm consenting them. It might be someone else down the track returning the findings. But yes, it's the role of the genetic counsellors in the lab. It is a research setting, so we really try to emphasize at every point as much as we can that the findings need to be clinically confirmed before acting on them. But we have set up a process where we kind of are as confident as we can be in a research setting. We don't want to be returning findings that we're not, you know, confident that they're relevant and causing a whole lot of unnecessary anxiety and follow-up.
And so yeah, for your clinically validated non-actionable results, so there's no patient pathway or screening program that people can join. Is it you that gives those results? And could you explain that process?
Yeah, sure. So this study that I'm talking about, the IPOP study, it was started long before I joined the team. And what was really interesting to me is when I was working in Australia, and I was a little bit involved in the Melbourne Genomics Health Alliance, which is a big study trying to figure out kind of the best way of offering secondary or additional findings to patients and really evaluating the process and the experience. And that was only for actionable findings, and, you know, very kind of new and carefully evaluated along the way. And then I moved to the US, took on this role, and since at least 2013 that participants had been able to receive or non-actionable findings from this study. So it's just vastly different than my experience in the two countries, and uncomfortable for me at first. And we have kind of a skewed participant population. You know, we're in the heart of Silicon Valley, very information-driven people. And so there's very high preference or uptake for non-actionable findings, around 90%, I think, of participants. We haven't had very many play out, actually. They've been quite rare. So in my experience in the last few years, that I've just returned one serious non-actionable finding. It was a gene that causes pulmonary fibrosis. So there's just not a good treatment or intervention for that. And yeah, I think, you know, it feels uncomfortable to have those kind of findings. But I guess some of the things that were helpful are kind of using the same skills in talking to people about uncertainty of penetrance and, you know, drawing in their reasons why they wanted this information and how that would be meaningful or empowering to them, and supporting people to adapt to, you know, unexpected results. And so I think it's the same skills. And I think, you know, just in my experience consenting a lot of participants, most, and again, maybe a biased population, but still very, you know, almost the real majority of my experiences have been that participants don't distinguish actionable and non-actionable the way that we do. You know, most people will kind of tell me, you know, they're the type of person that wants information, and so they don't bucket that information into different categories in the same way that we do. And they also talk about a lot of things that come up in the literature, like personal utility or, you know, motivation to modify lifestyle factors, or being kind of looped in to be able to participate in maybe clinical trials or other research studies, or be aware if there's kind of a change in availability of treatments or things like that. So it's been an interesting space.
So that's so fascinating. So there are obviously, I mean, we know this, personality types, aren't there, and profiles of people who will be information seekers or decliners. And as we move more into this futuristic space with multi-omics and wearables, whether people in a way will just self-select into those different groups because they'll either engage with the technology or they won't. So it's sort of part of a personality profile.
Yeah, well, I learned a new term since I've been in Silicon Valley. A lot of participants who enroll in our study and want a lot of information, they self-describe as biohackers. I don't know if other people have heard that term, but it means that they're gathering as much biological information on themselves as they can and looking themselves at the information and trying to generate insights. And so I learned that new terminology, and yeah, it's an interesting subset of people that really do put their hand up for getting as much information as they can.
Yeah, fantastic. Okay, so I can see a question from Annie Hassan, who's part of the steering committee. So I think Annie's asking specifically about the oncology clinic. So how often do oncologists refer to a genetic counsellor, or are they happy to reveal the result of genetic tests? So this is, I'm assuming this must be linking to Catherine and Stephanie's practice in cancer. So Stephanie, do you want to have a go at answering that?
Yeah, it depends. You know, some oncologists are perfectly fine doing this themselves, but the majority in our area are still referring. And I think it was interesting. One of our larger hospital sites that we have an extender group, the oncologists there used to do all of their own genetic testing. And once we started this partnership and offered this collaborative model, they kind of quit doing it. They saw the value and the benefit of having this done through our extenders and with the support from us. And now they refer everyone through the program to be tested that way rather than doing it themselves. I think they like the way that we manage the patients. And so I think it just depends on the comfort level and the resources that an oncologist has. That wasn't available before. As soon as it became available, they were very glad to, pass that off.
And Catherine, do you want to answer in your context?
Yeah, so I guess the model that we have is that when the genetic test result becomes available, it's sent to both the genetic counsellors and to the requesting non-genetics health professional. And if it's positive, then we will liaise with that doctor to say, flagging this result, hopefully you've received it. You let me know how you want to go about it. Like, do you want to be the one to disclose it and then we'll follow up, or would you prefer we disclose it? Only twice have I ever disclosed the results, so had contacted the patient out of the blue from their point of view, as in I'd never had contact with them before. And then in every other situation, in my experience, the non-genetics health professional has chosen to disclose the result. We follow up with the patient, quite quickly afterwards. So I don't know if it's them knowing that they've got that coming. They can sort of tell the patient, okay, this is your test result. You're going to get a call from a genetic counsellor in the next day or two who's going to be able to answer your questions and, have a more thorough discussion with you about this all. So they do it. I think just from what Stephanie was saying, a big part of the success of our mainstream program has been about the relationship between the familial cancer centre or the genetic service and the non-genetics health professionals who are doing the testing. And a lot of that comes from, I guess, a term I've definitely read in the literature around sort of mainstream champions. So having, say, oncologists and surgeons who have worked with us in the FCC through things like risk management clinics and through our multidisciplinary risk assessment clinics and things like that. So those doctors definitely feel very confident doing it. And I imagine their colleagues come to them possibly for advice too in the clinic, so that they can sort of continue to manage it outside of the FCC and then just bring the patient in after the fact, if that makes sense.
And can I ask a sort of cheeky question? So how about oncologists who are very, very happy to give genetic test results and just see it as, as a routine part of what they do, but who aren't necessarily considering the full kind of familial impact or are not giving the results in the way perhaps a genetic counsellor would? How do you rein that back in, or do you not? Or any thoughts about, oncologists who are perhaps a bit liberal with their use of genetic testing and feedback?
Yeah, similar to patients who maybe don't want to know information. There are definitely oncologists out there who just haven't engaged in the mainstream program. Some who are not doing testing at all, and some who are just like, we don't need you and we've got this. We see the fallout of those doctors, so they get positive results and don't routinely refer their patients to a genetic service. They manage them themselves, and usually we see the fallout when the relatives come forward to us, so their GP or whoever refers them into us, and then we're trying to chase the proband report and it all goes back. And anecdotally, I guess there's definitely been some confusion in the family or a bit of misinformation, or perhaps the proband isn't coping well, and you see that, and that's really challenging. And it is really hard, and especially in that story where we're not, I guess, affiliated or working closely with that doctor. So what can you do? You have this sort of sense as a genetic counsellor and a duty of care, and you just really want to get in there. And even, I know that I have had a family member come in and they've talked about the proband who's their relative and how they're sort of not doing so well emotionally. And I've sort of said, look, if she wants to give me a call or come see me, I'd be very happy to. But then, sort of stepping on toes, it's challenging.
That's really tricky, isn't it? And I suppose a lot of this is about the relationship that you're building, isn't it, with your mainstream colleagues as trusted partners. Did you want to say something, Emily, or was that just a scratch? Okay. Okay, great, thank you. So we've got a question about routes to become a genetic counsellor. Can I pause on that question, come back to it later if we've got time, because the quick answer to routes into genetic counselling is it depends which country you're in. Yeah, we can all talk about our own systems, but it's slightly different in each country. And then, okay, so this is a question from Stella Johnson for Catherine. You mentioned questions over how mainstream clinicians could consent patients for whole exome, whole genome sequencing. My understanding is that in the UK, many of our gene panels have been moved over to being a virtual panel on a whole genome sequencing test, including panels that are used by mainstream clinicians. Yes, meaning that the clinician needs to do the full whole genome sequence consent. I'd be interested to know the panel's thoughts on this. I'm a UK trainee genetic counsellor. So really the question is about consent. So the clinician, so an external clinician doing a whole genome sequence consent. Yeah, I mean, Catherine, do you want to have a go at answering that?
Yeah, so I guess I think this might be relating to something I mentioned earlier, which was that I guess in our mainstream setting, it is sort of a panel test. So, it's a distinct set of genes that are going to be analysed and reported on. And it's not an area I work in, so I definitely can't, I'm not an expert, but I guess I have colleagues who work through programs like what Emily mentioned, Melbourne Genomics Health Alliance and Australian Genomics Health Alliance, who are doing testing, whole genome testing, where, they might get incidental findings. And I guess the consent process sounds very lengthy and sounds really complex. Not a lot, but in some settings they're doing trio genomes, so they're doing the parents as well. So it's not just about consenting for, the person with the condition or the disease, it's also the parent. So it's quite a complex process. And also, I guess, thinking about what Emily was saying about her research participants, where there are going to be, say, non-actionable or secondary findings that people can opt into. I guess I feel like that. I feel like genetic counsellors should be doing that. It feels complicated to me, but it isn't my area. So I guess there's probably an element of me not having a lot of exposure to that.
Emily, do you want to chip in there about consent?
Yeah, I think, the difference between panels and exomes or genomes with the potential for additional findings. I think that does feel like something we kind of hold on to as genetic counsellors as really our area that we add value and we want to hold on to. I also, and I feel that way personally, but I also acknowledge there's been a lot of things that we've felt like that as genetic counsellors, and then as things evolved, we've felt more comfortable to share that role with others. So I guess I think back to what Stephanie was talking about before in terms of, really as a profession, we need a better understanding of who needs a genetic counsellor and who, who's going to benefit most from that and who may not. If you think about other serious medical decisions, a lot of, people make those decisions in their own ways, with their own kind of systems and support networks, and don't always necessarily need someone to help them facilitate that decision making. So I can imagine some instances where someone might, feel very equipped to decide if they want to know about serious additional findings without the support of a genetic counsellor. But I think there's many people who would benefit from a genetic counsellor, and we just still try to understand how to separate those.
Can I ask a separate question, Emily? Because I'd like to sort of bring in you and Alessia, thinking forwards to the future. What are you sensing in a research setting with your multi-omics work? Where are you seeing the clinical application soonest? Where are you seeing from the research setting the translation to clinical application in your multi-omic setting? What's going to be applied first?
I think, I don't know, my impression is that the low-hanging fruit, or maybe the area making the most progress the most quickly, is using other omes to help elucidate what could be a potential candidate gene for undiagnosed diseases. And will that be a research endeavor or a clinical test? I can imagine it heading towards a clinical test, but I think there's a while to go. And then in terms of the wearables that we've been working on, that's still in the research setting, but with some early promising data, and hopefully moving towards seeking like FDA approval for that to be, you know, a validated type of intervention.
And so, and could cognitive decline be one of the areas that wearables offering something useful clinically? So Emily, just and then come to Alessia.
Yeah, the area that my colleagues have been focusing on is detecting the onset of infectious diseases before symptoms appear, COVID, and also some other infectious diseases. And I know that in the US, there's a wearable company, a smartwatch company that's got FDA approval for early detection of seizures. And then wearables are being used as well for movement disorders, like monitoring people's gait or movement changes. So I think, yeah, a lot of areas that could be kind of developing.
Alessia, what's your sense on how close we are to clinical application?
Yeah, well, I mean, like most of the tools we studied in our study are still in the research and experimental phase, but there are some who are being piloted in clinical care, both specialist care, so talking about detection of cognitive decline, we're talking about memory clinics, but also in primary care. And one of the interesting questions, which again sort of makes me think of genomics and the discussion that Catherine and Stephanie and Emily have been having, is sort of what is the role, if I think of a GP appointment of 10 minutes, how can you fit the consenting process? We're talking about rolling out these tools in primary care. How can you fit? We know in the UK time for GP appointments is extremely strict. It's 10 minutes, one set of issue. How do you fit that in the time constraints? And yeah, sort of my previous project was on genomics, and one of the questions that we were discussing before, like about mainstream clinicians consenting patients and families into genomic testing, was one of the questions that I kept hearing over and over again. And one of the key things that often came out was not so much the skills, because I don't think that any mainstream clinicians would easily say, oh, I don't have the skills to do that. Because if I think maybe if they don't, they will just take part in training programs and try to upskill themselves, and probably they have quite a lot of genuinely, for good reason, confidence in the therapeutic relationship they might have with their patients. but it's also the structural constraint of how clinics are organized in different specialties. So one of the questions that I kept hearing often was genetic counselors and clinical geneticists have a lot of time to go through this information with their patients and families. And if you think of rolling out genomic testing or other more experimental technologies in, say, primary care setting with 10 minutes appointment, well, that raises all sorts of other practical and logistical questions, I guess.
Yeah, and I guess we have a very specific set of circumstances within our nationally funded health service in the UK, in that 10 minutes is what we get when we go to see our GP. And we don't really have the equivalent in terms of private healthcare settings, if, you know, there isn't really a great alternative for us. But for those who can pay, then you could imagine that a sort of two-tier healthcare system, which we do see, you know, in many countries around the world, where if you can pay, you can have all the time that you need to go through the consenting process and have access to the technology.
Yeah, which raise all sorts of other issues as well. Yeah,
absolutely. So we've got a question about VUSs. So this is a question for everybody. Do we have responsibility to do more functional research to validate VUSs, especially as we gather more genetic information from diverse populations? Who would like to chip in and make a start with that? Stephanie?
Yeah, so I think, again, this is an area where, as genetic counselors, maybe we set ourselves apart from other healthcare providers because we tend to leave no stone unturned, if you will. So yeah, I think we do have a responsibility to be thinking about this, track our VUS, you know, recognize when they get reevaluated. Certainly, most of us are trained to look for research opportunities for our patients and try to connect them with these opportunities to get these reclassified. And you know, certainly the focus on the diverse populations and understanding that in some populations that are maybe under-tested, we're not able to classify those VUSs as well as we would like at this moment in time. So yeah, I think we do have a responsibility to do that. I think that we rely a lot on our clinical laboratories to help us out with that. But yeah, keeping in mind what research opportunities exist and staying up to date.
Yeah, absolutely. Anybody else want to chip in with anything on that? Emily?
I agree that there's a equity issue there, and also a resource issue about, you know, where do the resources lie to kind of investigate further into VUSs. But as someone who does variant interpretation as part of my role, I would really advocate for, you know, if genetic services or labs are doing the work to, you know, segregate a VUS in an affected family, or, you know, do some additional functional studies, you know, getting that information out there so that then others can use that information too in their variant interpretations, I think is really beneficial, like writing a case report or putting it in ClinVar with the kind of summary information about the, you know, additional segregation data or those sorts of things, then really have a big impact for anyone else around the world looking at that variant and trying to interpret it as well.
Okay, I think we'd all agree with that. So question from Samantha Rojas. So this is about return of raw data. So while working in a Canadian multi-omics rare disease diagnosis research consortium, we refused to release raw data as we did not have resources to then counsel patients on what they might find in there, nor did we feel our public health system could take on these potential new referrals. The larger issue was also the potential for causing more harm relating to this data. Could you go into the rationale for your research group? That's over to Emily.
Yeah, I mean, I agree. I think those are really valid points to raise. And I think what to do with raw data is really tricky. I wasn't involved in the setup of this study, so I can, I guess, speak a little more generally on the topic from the US perspective, which I know is different than other countries. And the US is much more, I guess, consumer driven and information driven in terms of healthcare. There's really a big value put on patients having access to information. And there's a couple of relevant laws that I'll mention. The Cures Act, which was put into place earlier this year, allows much more free access for patients to their electronic medical records. And then part of the HIPAA law, which is the US healthcare privacy law, allows for patients, or it also applies to research participants, to have access to any health information that is collected about them that that affects decisions made about them. And so I listened to a really interesting talk from a lawyer at the NSGC conference last month, who was talking about how this part of this privacy law hasn't been really tested yet in court, but looks to be interpreted that it would include things like raw data and VUS and benign variant information. If people are asking for that, then there's a legal duty for healthcare services, and including research institutes that are covered by this law, to provide that. And so the reason I'm mentioning those things is I think there's a different mentality in the US about having more free access to information that maybe other countries see as not as appropriate to share with patients. So I think that's a big part of it. I think there are harms that can come from misinterpretation of raw data, of course, and we do our best to kind of guide our participants to kind of, you know, I think telling them not to use that data is a lost cause, but you know, at least I try to emphasize, like, you know, there could be a lot of false positives. So if something comes up, you know, just check in with me first. Maybe I can provide some context or some resources, or send you down to the right referral pathway. Don't panic at face value based on anything here. And I think probably that's the best we can do. But I know it's a area that you've done a lot of work in, Anna. So I guess, you know, that's just from my experience in the US.
Yeah, certainly in the UK, similarly, people have a legal right to be able to access their medical health records, and if a raw genome sequence is part of that, then they can access those. And I would argue, so yes, we did some research actually asking people, what would you do with this information if you had it? And there was certainly a sense of, well, if you know it about me, I'd like to know it too. So just a sort of pure ownership. If you've got information about me, I'd like to know what that is. And for some people, they really wouldn't know what to do with it, and assumed that you could just put it into Google, and then Google would tell you what it means. Through to, oh yeah, I've got some software lined up that I want to run it through, and I've got a bioinformatician friend who's going to help me with that, and I've already lined up exactly where I want it to go. Through to, yeah, it's just me, and I'd like to print off some of the data to have as a piece of artwork, or I just like to put it in the bottom drawer in the office because I know it could be important in the future, but not necessarily to do anything actively with it. So I do think, you know, when raw sequence data is made available, we do have a duty to sort of signpost people to, you know, what they could do with it, and some sense of I mean, we call it in the UK kite marked. I don't know if that translates into other countries, but a sort of have a system where you can say whether the provider is recognised, you know, does clinically good work or whatever. So it has some kind of mark attached to it where you're sort of endorsing external providers that they would handle the data sensitively. But you know, that's an enormous task to go around vetting what else is out there, and that really shouldn't be on us to be solving that. But yeah, I think there is a sense of, well, if you've got the data about me, I should at least be able to see it, and legally, of course, people can choose to access it. I know in the Genomics England project, I don't think there's been many requests to access raw sequence data. I don't think it's certainly something that people are, you know, coming to in the thousands. Don't know, Emily, if you've had many requests for a full set of raw sequence data.
Well, the biohackers do like the raw data, and often, you know, you describe the kind of different things that people might do with their data, and the biohacker type are the ones who usually have some bioinformatics experience, maybe themselves or have a friend, or they're going to play around with some tools and look at it. Yeah, so there's a subset of people who want to play around with their data. And I think mostly it comes from curiosity, really, rather than thinking they're going to diagnose themselves with something. They're really just intrigued about what this is all about and interested in it.
Okay, so we're coming to the end. I'd like to just go around everybody and see if you'd just like to mention a few final thoughts, or if there's any points that you wanted to make that you haven't had a chance to make. So can I start with Alessia?
Yeah, well, not really any points that I didn't have the chance to make, but I don't know, coming to these as an example, as a non-genetic counsellor person, I think it's really exciting to see how many of the things that, as I said, like we have been studying in our study, which seems very different and in many ways is a very different space, might be relevant to genetic counsellors in the future. And so, or actually maybe the other way to phrase it is more correct, how genetic counsellors and their skills and expertise might be really relevant to things that maybe are not immediately seen as relevant now, but that might become in the future. Yeah.
Thank you. And Catherine?
I think one of the really important things which we've touched on a lot already is just how important it's going to be to have some genetic training for non-genetics health professionals. And I think that's going to be a real key, is having non-genetics health professionals know enough to know what they don't know. I think if there's no knowledge, then it's sort of, there's definitely the potential for just, oh, I can do all of this and miss really key important things. But if they know enough to know what they don't know, and if they value the work of genetic counsellors, which I guess we need to advocate for, and the more experience they have with us, I think we prove our utility and our expertise. You know, all that needs to happen is one case where something curly happened, whether it's a complex genetic test result or psychosocial challenge. You know, immediately, I think the non-genetics health professionals, once they've seen how it's managed, they're just put at ease and then value that moving forward. So I think that's going to be key as things progress for our profession.
Thank you. And Emily?
I just think we should be so proud of our skills as genetic counsellors. We've just been talking about so many different ways that our skills can be applied in so many different contexts. And I think we're just so well positioned to be really at the forefront of the changes that are happening in healthcare. And yeah, I feel like that's something to take pride in.
That's a lovely note to end on. And Stephanie, what are your closing thoughts?
Well, I saw a late question come in, so I'll just, and it actually ties in nicely with some of my final thoughts is, I do think we need to work on how do we figure out who best would need genetic counseling versus seeing a non-genetic counselor. I don't have an answer to that question, but I know we need to work on it. We need to figure out what predictors are indicative of who would benefit most from a genetic counselor seeing a patient. So I think that's something to think on moving forward and work on. But I also want to put a plug in for outcomes, patient-reported outcomes. As we move into this new space of other providers doing genetic testing and evaluating patients, we need to have a way to make sure that we're providing quality care. So I think that that's something we need to keep in mind is how do we measure that? What is important to a patient within this space of genetic testing, genetic counseling? So keeping in mind these patient-reported outcomes. So a lot of work yet to do, but very exciting. And I agree with Emily. I think we're positioned very well in the way we're thinking about things and approaching genetic counseling.
Absolutely. And I think to end on that note, that this is all about service to patients and patient care and being able to evaluate to know whether this is actually what patients are needing and are benefiting from. Absolutely. It has to underpin everything. Okay, so we're out of time now. So our next live panel discussion will be tomorrow at 3:10 British Summer Time, and that's going to be on counselling supervision. So that's where we'll be exploring the support that genetic counsellors need to download difficult ethical cases or interesting dynamics, or anyway, support with the psychosocial aspect of their work and how they connect with counselling supervisors for that. So please do join us for that. And then we can continue the chat now in spatial chat. So two different ways. So either joining spatial chat or adding your questions, your thoughts, your views into the discussion forum threads that are within the portal. Don't feel too nervous about spatial chat. I haven't actually used it myself. I've been there and floated around a bit. But I'd love it if we could all go into spatial chat now and see how the software works. Then you can start joining and listening into conversations and see what people are inspired by and want to get answers to. So thank you so much for this session, and we'll see you in the future within the Congress. So thank you.